Hello and welcome to our sixth Kite perspective on the topic hospital, home and home care management. And today I welcome Dr. Robab Abdulkhani, who is a data lead and researcher for Monash Partners. So welcome, Robab, to our event today.
Thanks for having me, Anita.
Robab, would you like to tell us a little bit about yourself and the research work you've been doing in the past and what your role is at Monash Partners?
Yeah, sure. So I'm a health informatician and my background is in health IT and health information management. I did my PhD in health informatics at Melbourne University, which was completed in 2021. But it's at that time it was really ahead of its time, and it was forward-looking research that focused on data quality of health wearable devices that are used in remote patient monitoring. Currently, I'm a data lead, as you said, and a digital health project manager at Monash Partners Academic Health Science Center, where we connect 12 health care services and research and academic institutions to be able to translate research into practice. But today I'm here to present the practical framework that I developed on data quality that can be used in the hospital and the home programs for the audience to see how can we then implement such evidence-based practices into such programs.
Super interesting, and I see the slide deck is up already as well, which is great. But before we go into that, I have a personal question. Why are you personally so passionate about data and data quality in healthcare?
Actually, I've been quite interested in data quality when, as you know, the AI use in healthcare systems is really increasing, and these programs are getting more popularity, especially since the COVID pandemic hit. And we always talk about data quality. Data quality is one of the big challenges. It's really important. But I wanted to understand what data quality exactly means and who is involved in that practices and what's the responsibility of the stakeholders, and first identifying who are the stakeholders and all these kind of things to better understand the why when we say that we have the challenges. And that's actually pushed me toward understanding data quality in this context of hospital and home programs, because we already have traditional definitions of data quality in healthcare for paper-based or electronic medical records. So bringing this knowledge and enthusiasm and interest for understanding this in these novel programs encouraged me to do this research.
Yeah, I love it. And it is so relevant, specifically in the healthcare, is having accurate data and, focusing on what actually are the dimensions of data quality, I think is really, really important. But I hand over to you now to tell us a little bit more about the framework and the recommendations you have for that space.
Absolutely. So as we just talked about this, that hospital in the home is a level of broader concept of remote patient monitoring that's revolutionizing healthcare delivery by offering unparalleled patient convenience and bringing care to the patient's environments. And these initiatives are powered by sophisticated AI-enabled wearables that capture vast amounts of real-time patient data automatically and offer unprecedented insights into the patient's health status. So today I want to share a practical framework that can help ensure the highest standard of data quality from these tools and enhance the effectiveness and reliability of these programs. You all know that the intelligence of these AI systems is only as good as the data it receives. If the machine learning model embedded in the wearable is trained, validated, or deployed on poor quality data, plagued with non-representative inaccuracy, missingness, or messiness, then the AI's output, whether it's an alert, trend prediction, or a diagnostic aid, can be flawed, and it will underperform to the detriments of patient safety. But when discussing data quality, we predominantly focus on evaluating the quality of an individual AI application in the wearable device in isolation. But AI systems like wearables and more broadly the hospital and the home programs should be considered as socio-technical assemblages rather than just collections of codes and data. And why is that? Because we have four overarching elements here. The first is the human actors. Since these programs run in the patient's home, the patients or caregivers primarily supervise the wearable functionality and might be required to enter some data manually, either into the device or the app or the portal that's associated with it. On the other side, we have clinicians who are directly involved in these programs, and they read or interpret those insights to make decisions. And any other non-clinical staff who are involved in these programs as well that need to clean the data or provide education to the patients. We need to make sure that all these people understand data quality. Then we have the technology that it's about the device itself and the interaction with other devices. Although most of these wearable devices are medical grade and pass the evaluation and the validation in the lab, but working in real world doesn't guarantee high quality data will be captured. And we have the processes, which is the interaction between the human and that technology at the data collection point, and between different technologies, and also the interaction between patients and clinicians when they get the insights for the consultation. And these three elements work within the internal structure of the healthcare organization that might be impacted by policies, data governance frameworks, funding resources, etc. And then all of them might be influenced by external issues such as new regulations or economic changes. So that's why we really need to look at hospital and the home programs as a socio-technical system. Now let's dive into the meaning of data quality in this context. There are lots of governance and data quality management frameworks developed in Australia and internationally, like by the World Health Organizations, and focused on data quality from health information management perspective, which is the quality of either paper-based or EMRs, and some frameworks that look at data quality from biomedical engineering perspective that merely focused on the formulas or algorithms. But I wanted to know what data quality means in the context of remote monitoring or hospital in the home as a socio-technical system. So as you see, I extracted 7 common aspects of data quality, and I evaluated them through a couple of studies that I'm going to explain later on, and the characteristics of them to see which one would require attention. So the 3 elements of people, process, technologies within the whole structure of the healthcare organization and the program would impact data quality, and we need to understand that. So we began with a literature review, and then we concentrated on 3 case studies, including diabetes, cardiac arrhythmia, and sleep disorders from sophisticated tools that require lots of interaction to simple tools that work autonomously. We examined the remote monitoring processes, the wearables used, and conducted interviews with the individuals involved in those scenarios to identify the challenges related to data quality. And that was carried out in Australia, the US, and the UK. And then I brought the identified challenges into a participatory workshop to understand the solutions and what they actually expect from each other to be able to practice data quality management from wearables. So that workshop focused on the main stakeholders and their expectations from each other. And then I brought the findings from these 3 studies into the 4th study, where I synthesized and interpreted the findings and translated them into recommendations. And in the last stage, I did an international survey by Delphi method to understand the importance of this guideline for the safety and quality of remote monitoring programs. So all of these studies have been published in peer-reviewed journals. And if you're interested to learn more, just email me or just go to my profile on Google Scholar and download the full text. So now I'm going to talk about the framework itself, and starting with data accuracy aspect, which we defined it when data are free from errors. The first thing was about calibration. Some wearables might need one-off calibration before starting data collection. Some other require calibration a couple of times a day throughout the collection, but we found that the advice on how often and when to calibrate isn't based on the clinical standards of care. Usually patients go to the vendor website to get advice, but some clinicians disagreed and wanted these to be based on the clinical standards of care. And it's still taken manually, which might be erroneous. So this guideline suggests that the calibration can be done automatically to whatever possible. Also, some elements like meals and mood and some other data still are captured manually, but there are some other tools like consumer wearables, fitness trackers can capture them automatically, but there is no mechanism to connect these tools together. So we need to pay attention to that. And the third item is the annotation of either manual or automatic entries, which is absent in most wearable platforms, and would really help to correct some inaccurate data immediately. The other item is accessibility, which means data availability to authorized users. Although it's not about the data itself, but no matter how accurate the data is, if it's accessible to the authorized user, is still considered as low quality. Some wearables are blinded and don't show raw or processed data to the patient or the clinician during data collection, and some are deliberately disabled because of clinical purposes. But as you know, the new generation of wearables that let patients access the data once they capture them would engage them in their health and help in catching some behavioral patterns or changing the behavior if needed, and to move from passive to active participants in their health management. And even the same with the clinicians. Some of them really wanted to get access not only to the processed data, but even to the raw data. The second one is getting routine notification on data access, and that's highly depends on defining data ownership principles that needs to be clarified at the beginning of the intervention. And the third is the dynamic consent. Most patients weren't satisfied with the single click on the terms and conditions of the consent they get, or the consent form that they get from the clinic, but rather dynamic consent for different levels of access to their data. And the third one is completeness, which means that no data is missing. And the main reason for repeating data is when we have incomplete data reports. Sometimes the device isn't working properly. Sometimes the patient take it off because of lack of motivation or because of being a burden on them. But if there would be a predefined protocol to specify some downtimes during a day based on clinical standards and in conversation with the clinicians, and then resuming data collection to make sure that sufficient data could be collected to make a decision based on. Also, the annotation functionality that I mentioned in the accuracy slide would help to report the reason for missing data to find a solution for it. The other one is consistency. That means that wearables, regardless of their platform, they can convey the same message. Still, most data, whether captured from consumer or medical grade wearables, don't have clinically accepted definitions or standardized format. Each wearable has its own way of presentation. But how can we make sure that clinicians getting this data from different tools would be able to understand all of them? Or should clinicians limit patients to use a specific brand of wearables that they're familiar with? But when we talk to them, they wanted to give patients the authorities on choosing their own favorite tool, but they're also concerned over time that people might use different tools, and they expect the clinicians to be able to interpret all of them, and they really can't cope with all these changes. The second one is the integration with the EMRs, that not all the platforms are having that integration yet, but would really change lots of things. So then no matter what platform those wearables are coming from, they can be cleaned, analyzed, and extract meaningful information when they come to the EMRs and be integrated into the medical record, the patient's record. The third one is actually the item of exchanging data. That's still a big challenge even for clinical data. So if wearables would be considered as a valuable source of for patient care, it should be treated similarly. And we need to think about consistent exchange between the data. The other one is interpretation, or the data interpretability. That means that data presentation would show the key message to the users. It actually has lots of overlaps with the consistency that I talked about earlier, and it was the most dominant issue reflected in all of those 5 studies. Wearables lack metadata or contextual data to inform the clinician what the patient was doing at the moment of data collection that caused that ups or downs in the trend. Although some devices enable patients to take some notes, but it would be better to capture them in a more systematic way through interaction with the patient. For example, if the chatbots powered by the large language models can integrate with the captured data in real time, they can identify some behaviors that can't be recognized otherwise. Also, a few wearables give alarm on the out of normal range data. But we know that not all of the patients are highly literate to understand the out of normal range and what would happen for them if that occurs. So clinical advice can be attached to the alarm to improve patient awareness. Also, most current wearables provide a snapshot as a PDF and maybe show interactive visualization through patient portal, but only to the patient, not to the clinicians. But clinicians wanted that interactive visualization to be presented to them as well. The other item is relevancy. Apparently, data relevancy doesn't need more explanations, but the findings show that some wearables don't actually include relevant data, and some relevant data aren't yet defined into them, and not all the captured data are relevant. So clinicians need to spend lots of time to identify the most important information there. The last item is the timeliness, which is about the time of accessing the data. And still, no protocols exist to define data availability either on ongoing or periodic basis and remote monitoring of one type of disease. For example, some wearables of the same type are blinded. Some others show data during data collection. Some clinicians can only get the report at the clinic, some get it remotely. So it would be really good to define that at the beginning of the intervention. Most clinicians reported that would be good to have a mechanism to share data in real or near real time, and that would enable them to notice some issues and identify some causing habits and behaviors rather than just relying on patients' notes. So these are all the recommendations, 17 recommendations from 7 aspects of data quality. And here I want to show that I classified them based on data management processes when data are collected and then are transferred and reviewed by the clinicians. And as you see, all of the 7 aspects of data quality are really important at the collection side when the patients interact with these outside the 4 walls of the clinical settings, and they have the responsibility for changing the settings or interacting with the device or entering some data manually. So that's all about this framework. Try to make the story quite short.
It's super interesting. Do we have an echo here? No. All good now. Super interesting, and you touched on some really interesting points where in my mind where we're focusing on the home care hospital, the home solution and enablement for organizations is like that decision point for an organization to say wearable data is actually considered valuable data, which should be collected and transferred into a hospital's EMR system. Practically speaking, are hospitals doing that today?
That's a good question.
Do you have any insights on
that? When I did this research, it was actually challenging to find some participants because I realized that this type of work is limited to some clinical departments and it's not at organizational level. So those people who are health informaticians or health information managers, they didn't even know about those programs. But then after the pandemic, there were more of kind of projects around this and more efforts towards integrating it with clinical workflows. But I don't have, a specific number of healthcare organizations that are now using it as part of routine practice.
No, I fully understand. And, it's like in my mind is like, organizations could actually use wearable data, sync it through cloud into the EMR system, have it analyzed, in context of their health conditions, and then flag it for review if there's any values off the charts. So someone is actually doing a proactive outreach and saying, hey, we just saw the data come in from your wearable, are you feeling okay? Or do you want a nurse to come in sooner than later? Or do you want to come and see us in the hospital? Or whatever the scenario might be. But the other question I have for you, what are some of the practical tips on how to implement something like that? So I think there's an understanding that this is, it may not be something quite yet what hospitals or organizations are doing to actually have this as part of the overarching healthcare data of a patient. But if organizations would be looking to implement something like this, what are some of the tips you may have for them?
I would say that it's still a bit challenging to convince healthcare systems to use evidence-based practices. But in my current role in a research translation center, we're now learning on how to help building up multidisciplinary teams from the very beginning when an AI project needs to be developed in academic side in partnership with the industry side to make sure that it meets their their needs. And for implementing this, I've been working on providing an action plan to better work with the healthcare systems to understand what they want to, implement in what way. But I think the main things that we need to consider first is to have that technical infrastructure with the healthcare system, as you mentioned, like having the integration with the electronic medical records and making sure that we have that technical capability out there. The other thing is the digital health literacy. Like all those stakeholders involved in these programs really need to be aware and understand this data quality, for example, and also considering the internal policies that we have, because this guideline that I introduced can't work by itself. We need some governance framework, some funding resources, some regulations, and the adoption across the whole healthcare system. But if we want to limit it to short-term, small-scale projects, this is what so many healthcare systems are doing at the moment, which is very much isolated. And after it's finished, then there is no way to continue this and implement it large scale.
It needs to be done in a wider context with a clear view on overarching solution and data architecture and strategy for sure. But the interesting aspect also, while we're talking so much about data and data quality and acknowledging data as valuable data to be actually used on a systematic and regular basis, it actually comes down to human-centered care, doesn't it? Because with that data, what we are trying to do is actually improve the services to the patients and to the humans.
Absolutely. And I talked about that concept a couple of years ago in a conference, that we need to move from disease centricity in these programs to human centricity. And that's especially important for data quality when people are suffering from comorbidities or multimorbidities, when they use more than one wearable device, which is connected to its own app and to its own portal, and that targets one specific organ of the body, whereas we have only one human. So that human are dealing with so many different devices that don't talk to each other and don't interact with each other, and that person has to supervise all of them while living their own daily life. So when we talk about this program, we really need to first make sure that how many tools the person is able to use, and whether we can provide solutions to let those different tools that capture different data types from different organs to communicate with each other, to provide more holistic view of the patient's health status. And that would really reduce the burden on patients and having better communication with their clinicians, and for the clinicians as well, when different clinicians in different departments can communicate with each other, and not just having one hospital in the home or remote monitoring for one particular disease. And I really saw that in those 3 case studies that I've done.
I could not agree more. And, having a father-in-law in and out of hospitals at the moment, I can also see firsthand, home care management is so important, but also not having that isolated view, right? You talk to one specialist, they give you one thing, you talk to the next specialist, they give you something else, but you actually need to zoom out and look at it cohesively, and have that end-to-end view to really make sure that, I guess, a patient gets the best service and is looked at it from all the things which are going on with them at the point in time. I'm just realizing time's up. Oh my God, that went so fast. If anyone from the audience would like to get in touch with yourself, Rabab, what would be a good way for someone to reach out for that implementation action plan or any other follow-up questions they may have?
Absolutely. So I provided my email address at the beginning, and I'm happy to have a chat, have a coffee with someone and talk further about this. Unfortunately, if we didn't get enough time to go through the questions, I'm happy to have more chats if anyone is interested.
Yeah, perfect. Well, thank you so much for spending the 30 minutes with me on diving into data quality and home care management, specifically on wearable devices. I really appreciated your time and your preparation for this. And I'm sure we continue talking about this in coffee catch-ups afterwards. So
Thanks, Anita.
thank you so much for the audience, and have a good day. Thanks, Rabab. Bye.
Thank you. Bye.